All right, I want to welcome everyone to NAMI Davidson County and Vanderbilt Behavioral Health's first collaborative education session of the 2025 calendar. We've been hosting sessions with VBH for over a decade, featuring some of the best minds in the mental health field. But before we start tonight, I want to do a few housekeeping notes. The session's audio is being recorded for our YouTube channel, so please make sure to mute your devices and the Zoom when not asking a question. If you're not comfortable asking questions during our question and answering session, please feel free to use the chat function, and Eileen Wolf, our caregiver coordinator, and myself will ask them for you. And I don't believe I told you all, I'm Don Liacono. I'm the Chief Program Officer here at NAMI Davidson. I've been at NAMI Davidson for almost 4.5 years now, and I'm in charge of most programming and outreach. I'm the first contact for our affiliate. I've also put in the chat links to our upcoming Well Within Awards tickets, where we're recognizing people who've done good things working with youth in our communities, especially in the mental health field. I also have included our website calendar of programs and registration for our May 17th NAMI Walks Middle Tennessee, which it will be back at First Horizon Park, the home of the Nashville Sounds. So tonight's session is on supporting loved ones with a substance use disorder, a topic close to me as I am someone who self-medicated with alcohol throughout my 20s and 30s, and I still have to manage those tendencies today in my 50s. There are times where with my depression and my OCD, I want to go back to self-medicating, but I know the issues that caused. It only worsened my mental health. So tonight's topic is definitely dear to my heart. So now I'd like to introduce my colleague, Tracy Glasgow from Vanderbilt Behavioral Health, and she'll talk about their services before she passes the program over to our guest speaker, Dr. India Reddy. So Tracy?
Yes, hey, thank you, Don. And it's nice to see all of you here, and I see some of our Vanderbilt folks on the call, so it's good to see you. I just wanted to mention a couple things. At Vanderbilt Behavioral Health, we offer an inpatient acute care for co-occurring disorders, and that is substance use disorders along with co-occurring mental health diagnoses such as anxiety and depression and other things. We also offer an intensive outpatient program for adults that provides a track for co-occurring disorders. So we have a couple levels of care for co-occurring disorders that we offer. And I see that Rayanne, who works in the program, jumped on the call earlier, but she's actually finishing up, actually working in the program this evening. The hours for that are 4 to 7. So she's probably not quite off work yet, but she's trying to join us. So she may be able to say hello at some point during the session.
Hey, Tracy, I'm here right now.
Yeah. Oh, hey, Ray. How are
Hey,
you?
good. How are
Hey.
you?
Good. Thank you for joining us. I know you're probably trying to tie things up this evening, but I just wanted to introduce you and wanted to see if you wanted to say anything about the IOP program.
You're absolutely right. We are in programming right now, so I'm trying to be a little bit quiet. But yeah, our program is Monday through Thursday. We meet from 4 p.m. until 7 p.m. Like Tracy was saying, we have the co-occurring track. So in our program, we are looking at how is my mental health impacting my substance use, or how's my substance use impacting my mental health. Our program lasts for about 5 weeks. It's 20 sessions. And I think that's all I got right now. Sorry.
Yeah, that's okay. The hours are 4 to 7, so hopefully, folks can come in the evening with minimal disruption to their day. So I just wanted to mention that as well. We've got a great team in place there. So, and I think that's about it. Now I think I want to turn it over, which everybody came here to hear. Dr. Reddy, I think, has an amazing presentation for us this evening. So I'll turn it over to you, Dr. Reddy.
Thank you so much, Tracy. I'm just going to share my screen now. All right. Can you see that now? I think we tested it earlier and it seemed to work. Okay, great. So thank you for that introduction. I'm really excited to be giving this talk and to have been invited by NAMI. I know you all are doing great work. kind of getting the word out about, different mental health issues, resources, and that sort of thing. So I'd like to do that for substance use disorders, which is my area of focus. So I am board certified in psychiatry and addiction psychiatry. Did a fellowship in addiction psychiatry, and now I'm working mostly on the inpatient unit at Vanderbilt Psychiatric Hospital. So that unit that Tracy just described, where we treat co-occurring substance use disorders and other mental health disorders. And I apologize. I've also had a little bit of a cough, a little colds last week that I'm getting over. So you may hear me cough a little bit, but hopefully not too bad. And so I mainly work on the inpatient side, but I also do a little bit of work on the outpatient side. I work with the recovery clinic over across the street from the Vanderbilt Psychiatric Hospital, where we have a really collaborative team-based program where we treat substance use disorders, also co-occurring mental health disorders of all sorts. And we have groups, we have different kinds of medication treatment. We have individual therapy. So really a well-rounded program, I think. I think we do a pretty good job. So I will be talking a little bit about some of those resources, those kind of levels of care. And my talk is really targeted towards individuals who know people who are struggling with maybe substance use or substance use disorders. So those might be friends or family, and for some of us, it's part of our work. And those are people we care about too, obviously. And some of this may also be relevant for folks that are going through, problems with substances. So hopefully, this is something that you all find interesting, relevant. I will say my background, I have a medical background, but I also have a PhD in the neuroscience of addiction. So I'm going to talk a little bit about that too. All right. So tonight's agenda, I'm going to start by talking about the difference between substance use versus substance use disorders. They're not exactly the same. And there's some distinctions there that may help to understand when it might be time to get certain kinds of help. I'll talk again about the neuroscience of substance use disorders. I'm going to keep it, I think, pretty accessible. So I'm not going to go into the nitty gritty, but kind of talk about the big picture of the neuroscience. I'll talk about some of the signs that someone might have a substance use disorder, some things you might notice or look for in someone that you're worried about. I'll talk about resources and levels of care. So again, talking about, those different places someone might go that we have started describing. Talk about that in a little bit more detail. And then I'll discuss how to support someone. So that person may or may not be ready to get some help. So how do you talk with them? How do you support them, whether they're at that point of getting a little bit of help or not yet? So what's that difference between substance use versus a substance use disorder? And I'll call that SUD in certain places in this talk, just to shorten it. So not everyone who uses a substance has a substance use disorder. As I'm sure you know, a large percentage of the population can use certain substances and not develop real problems associated with that. So for instance, the percentage of Americans who drink any alcohol has remained pretty steady, around 60% for the past century. And so 60% will say they have some drinks, doesn't have to be a lot. And then 40% say they have abstained from alcohol pretty completely. About 10% of the American population will develop an alcohol use disorder, which is certainly not nothing, but it's not that full 60%. And so, we kind of distinguish these things on certain factors. And so the short answer to what defines a substance use disorder is problems, right? It's problems that really impact their ability to function. So these problems can vary in their severity and their quality, right? So some problems can include hazardous use, so using substances despite it putting them in dangerous situations or harming their health. continuing to use despite knowing what it's doing to them. It can lead to problems in social problems, relationship problems with spouses, siblings, children, those sorts of things, and neglecting roles and duties. So, folks may know their roles and duties, but sometimes when substances take over, those things go by the wayside, and those individuals are seeking the substances at the expense of those duties or those individuals that they really do care about. They may give up on once loved activities as well. They may use more and more of a substance, and may need more and more to get the same effect. Or they may spend more time using, going out of their way, getting the money to use their substance of choice. And there may be repeated attempts to control you. So that's not necessarily a problem in itself, right? But it kind of indicates the underlying problem, which is that they're not able to quit. They're trying over and over again, and it's not working. And so repeated attempts to kind of control their use may kind of indicate certainly that there's a problem going on there. Physical dependency can be a part of a substance use disorder, although I would say it's not the only component that's important for diagnosing someone with a substance problem. As we know that people who are prescribed certain kinds of medications long-term, like opioids, can experience things like withdrawal when they suddenly stop an opioid, for example, which doesn't necessarily mean that they have a substance use disorder. But certainly it is one of the things we think about when we're kind of looking at the whole picture. So withdrawal, craving, those kind of physical properties that develop after using substances for a long time. And then physical and psychological problems related to use can also occur. So problems with mental health. We talked about at the beginning, sometimes people self-medicate, but also we know the opposite can occur, that mental health problems can be caused or worsen related to substance use. And certainly physical problems can occur. With alcohol, we think about liver problems, cirrhosis, problems with the pancreas, cardiovascular problems with stimulants and even alcohol and other substances. So certainly we know that substance use disorders can have a lot of these physical manifestations. So who do substance use disorders harm? So the individual, of course, can be harmed. We talked about problems related to mental and physical health, inability to function. It can harm children and families, and it can harm society as a whole. Someone who's not functional is maybe not contributing to society in a way we'd hope for. And so that can lead to leaning on others more than they would otherwise. It can lead to not contributing. So housing instability, criminal behaviors, either as a victim or a perpetrator. Individuals who have substance use disorders are putting themselves often in high-risk situations, so they're often more likely to be victims of criminal behavior. Incarceration, transmission of diseases like HIV that are associated with intravenous injection drug use or high-risk sexual behaviors, and unemployment or dependence on welfare. So it has a cost to society, both in how the society functions and sort of those real economic costs. I do want to say that just because someone might not meet those criteria for a substance use disorder doesn't mean that they're not being harmed by a substance. So substance use by itself can be harmful, even if they don't qualify for a substance use disorder. So how does that happen? Here's some potential harms with substances that kind of came to mind for me, and this is not an exhaustive list by any means. We know certainly that some substances increase risk for cancer. We think of tobacco use often with cancer risk, but even alcohol. There's a recent sort of guideline that came out from the government kind of saying that alcohol, even in small amounts, can be harmful in terms of substantially increasing cancer risk. So we don't fully think that any level of drinking is completely risk-free. That said, there is, I think in life there's always some risk that we're willing to absorb in our day-to-day lives. So there's always a balance there, right? But substances don't necessarily come with no risk, and I think these are things to think about, right? And weigh them in your mind. Psychosis, we know that can be harmful. So even if someone has only used a couple of times, maybe they haven't been using enough to even qualify for a substance use disorder, and demonstrating those problems, they can develop problems with hallucinations, delusions, paranoia, that sort of thing. We think these things happen more with things like cannabis, hallucinogens, stimulants like amphetamines and cocaine. So those things can be harmful, especially in individuals that are a little predisposed to psychosis in some way, maybe with a family history, but even in folks that don't have that history. Accidents are a big source of harms that don't necessarily come with a substance use disorder. Even kind of a heavy night of drinking once on New Year's Eve, and then going out and driving home and causing an accident, that's a big harm that's related to substance use. As I mentioned, people that are chronically kind of taking certain kinds of medications can experience withdrawal if they don't have access to it, or miss a dose. And developmental problems is another thing I think about, especially when starting using substances at a young age. And there's evidence of developmental problems in utero for pregnant mothers that may be using at the time, even if they don't necessarily meet criteria for substance use disorder. And one thing I didn't put on the slide, but death is something that can occur even from a single use of a substance. And I think that idea is sort of being promoted a little bit more, because we know that things like fentanyl that are really pretty dangerous and fatal in a small dose can get into, and it is getting into the supply of a lot of different substances. So sometimes people are buying what they think is one, kind of off the street medication or drug, and they think it's one thing, but it turns out to have fentanyl in it. So they're really scary still. And so I want to talk a little bit about the neuroscience of substance use disorders. And again, this is something that was a bit of an interest of mine. Going through my PhD is still an interest of mine. I'll try to keep it light. So why are our brains susceptible to substances in the first place? And I conceptualize this around kind of the evolutionary process. So our brains evolved in a time when we didn't have access to the donuts here on the right. We evolved maybe with access to what's on the left here, some meat, but also other scarce commodities, right? And we had to survive, and our brains told us what we needed to survive. We didn't have a book. We didn't have a guide saying we need this to survive most efficiently. Really, we needed a signal that said, this thing is calorie dense and it's good for us. We should go for it. This is going to give us the most bang for our buck, right? And so our brains told us through our reward system that certain things taste really good. They feel really good when we eat them, and that we should go for that more. And so what we know now is that a kind of internal part of the brain, a primitive part of the brain, signals to us through the neurotransmitter dopamine and other signals that that certain things are rewarding, and they're going to help us survive, right? And so back when we were more resource limited, things like on the left would give us that dopamine spike. Nowadays, a lot of us have a little bit more access to foods, high calorie dense foods like the donuts. which are a little bit more processed, but still kind of give us that that dopamine surge. And it's been a little bit maladaptive, right, in our current society because we have such access to those things, and that's led to things like obesity. So what some of my work was in my PhD was sort of understanding this overlap between food reward and drug reward. So what we think drugs are doing is they're really coming in and hijacking the system that was developed for food rewards, but also other natural rewards, things that bring us natural pleasure, that are important for survival, truly important for survival. So things like sex or making someone laugh, like being in a social environment and making someone else happy gives us pleasure, maybe because that was a way of being social, and being social was a way of survival. So our brains developed to help us survive and teach us what were those things that were going to help us survive. And drugs kind of came in later and just took over that system. Drugs don't help us survive generally, but they've sort of co-opted that system that was already in place and give us that dopamine surge as well. So on this slide, I'm going to talk about that part of things. So on the left, we've got the natural rewards, food, sex, making someone laugh, etc., giving us this like kind of modest dopamine rise. So we're seeing an increase in the neurotransmitter dopamine in the brain's reward system, the brain's reward center. What happens when substances, let's say cocaine comes along, let's say it's being snorted, it's getting into the bloodstream fairly quickly. Maybe not as quickly as, if the drug were injected IV, but it's getting in pretty quickly, and we're getting this sort of really quick spike in the dopamine, and it's going even higher than the dopamine spike for natural rewards. And this is common to pretty much any drug, including things like alcohol and tobacco. What this is telling our brain is like, this is good stuff. This is stuff that makes me feel good. It's rewarding. And it gets misinterpreted by the brain in a way that this is important for survival, because that's why the system developed in the first place, was for survival. And as people have more and more of these spikes in dopamine, their brain learning systems are also kicking in, saying, this stuff is good. I need to learn how to get more of it. And so that's sort of how addiction can develop. And so we know that there are a few different brain regions involved in this whole process. I'm not going to go into detail on this, but we think that there may be different stages of addiction related to substances. So the first stage is really that kind of dopamine surge stage, this binge intoxication stage, which we think is mediated by a brain region called the basal ganglia. You don't have to remember that part. So binge intoxication means someone's using it here and there, they're getting intoxicated, they're having that pleasure effect, and it feels good. And they're maybe doing that repeatedly and then kicking in those learning systems, right? There comes a point too when someone's using substances for so long, they almost get sick of it in a way. It starts to have some negative effects on them. They're starting to notice maybe it's not making them feel good. Maybe they're having periods of time where they don't have access to it, or they're needing more and more and they just can't get enough, because the brain also adapts, right? The brain gets those hits of dopamine and says, okay, well, over time, this is the new normal, right? And if this is the new normal, then I have to recalibrate. So the brain's recalibrated. It needs more and more to get the same effect. That person may not be able to get more and more, right, to get that effect. And so they're feeling the withdrawal, the negative side of substance use. And that can lead in some ways to more use, so or riskier use. So if they're not able to get it by their normal means, maybe they're going out and doing riskier things to get the substance of choice, or maybe they're using a more potent substance, something stronger. And so sometimes we'll see individuals who used opioids that were prescribed to them for a while, but then transitioning to things off the streets that may be in some ways easier to access or more potent. So they're able to get what they need, but they're still in this cycle of withdrawal and feeling bad. And so sometimes then, of course, people want to get out of that cycle, and that can lead to making a change. And at that point, if they've been able to cut back or stop, they may even enter another phase of addiction where they're still craving it. They've still got those memory traces of the substance. And so this is the preoccupation anticipation phase where, they're thinking about, some of the cues that they associated with their substances. Maybe they're still around people that they use substances, and that's sort of triggering for them. And so they're still thinking about using substances, and sometimes that can lead to relapse. And some of that's kind of controlled by the prefrontal cortex. And so the prefrontal cortex, this front part of the brain, is a more advanced part of the human brain that helps us with decision making and helps us with impulse control. And so it's sort of trying to regulate some of those impulses, but not always winning out. And so sometimes that can lead to relapse and thinking about going kind of back into that binge intoxication phase. And so sometimes this cycle moves through and through, unfortunately. So why do some people develop substance use disorders and not other people? And so, we don't have all the answers to this question, but we have some ideas. And like I said at the beginning of the talk, not everyone who uses a substance will develop a substance use disorder. This is a really complex question to try to answer, but do my best here. So we, first of all, think that environment and access to a substance is important. So someone who doesn't have access to a substance, even if, let's say, they have some other predisposition to a substance use disorder, is never going to develop that substance use disorder, right? If you don't have access to cocaine, and you're not seeking it out or anything, and no one else in your environment is using it, it's unlikely you're going to develop a cocaine use disorder. So environment is obviously really important. We think also that earlier onset of use is a risk factor for developing substance use disorders. So this is in part because they are maybe, let's say if they're starting around the age of 12, they have many years where they're just used to being around substances or using substances. And also their brain is developing within that context, right? So the brain doesn't kind of fully develop until age 25. So if you're using between the ages of 12 and 25, that's a brain that's fundamentally changed by substances. And that's not to say that someone can't get through that or that they will absolutely develop a substance use disorder, but just to say that is a risk factor for having problems with substances later in life. Genetics is something to mention. It's a significant kind of contributor to the risk for substance use disorders. Again, if someone has genetics to support a substance use disorder, if they don't have the access or maybe some other environmental factors, it's unlikely they'll develop one. But we know that a combination of genetics across the genome may be responsible for up to 50% or somewhere around that of variation from person to person in their susceptibility to a substance use disorder. And this varies a little bit from sort of substance to substance, but kind of around that range.
Thanks for bringing that up.
Yeah. And it very much interacts with the environment. So I just really want to make that clear. And it's not just one gene, right? it would be very, very rare for us to, to sequence someone's genome and say, this is the gene that's causing your problems, right? That's not how the genetics of substance use disorders work. If it were the way it worked, it would actually probably be a lot easier to treat and to understand. But we think it's a lot of small different changes sprinkled across the genome that can contribute collectively to the genetic predisposition to substance use disorders. But certainly, we do see this kind of genetic predisposition in families. Part of that may be the environment, growing up kind of in similar environments, but also we think that the genetics is a component there. And just because someone has the genetic predisposition does not mean that they will develop a substance use disorder. And right now with the field of genetics, we're not at a place where we could sequence your genome and even look at those that sprinkling of genetics and say, this person is likely to develop a substance use disorder. We're really not at that point with the research yet. And so I also want to make that clear. But one day that might come down the pipeline. We also think that some people develop substance use disorders because they're coping with other mental and physical pain, right? So it may be that they are self-medicating in a way with substances to numb the pain of either a mental condition, whatever that might be, or physical pain. We also know that certain mental health conditions predispose people to substance use disorders just by their nature. We know that certain mental health conditions that increase impulsivity can increase the risk of substance use disorders. You're more likely to impulsively try something or take a risk, right? So that is something else to mention. And then finally, there are different abilities to regulate impulses. So I think one extreme of this example would be someone who's had a traumatic brain injury, maybe to that frontal lobe, that part of the brain that's really responsible for good decision making and impulse control. So if someone has just damage to that region, that may dampen their ability to regulate those more primitive parts of the brain with that frontal part. And I do also, so there's several different disorders that could kind of fall under this category of differing abilities to regulate impulses. I do want to point out, though, that I truly don't think a lot of substance use disorders at the point of developing a substance use disorder is a fully a matter of mind over matter, right? So you can have a really strong kind of frontal lobe or fully functioning frontal lobe and hasn't been damaged and still develop a substance use disorder. Sometimes that sort of primitive part of the brain, the reward part of the brain, has just been so hijacked that that frontal part just can't compensate for it. So where someone might be good at making decisions and have that fully functioning frontal lobe in other scenarios, maybe when it comes to their drug of choice that's already hijacked the system, that's just not, it's not possible for them, or it's going to take retraining of the brain and maybe some time away from the substance before the brain can recalibrate a bit and dampen down that kind of reactivity of the reward system. So it's a complex kind of answer here, but a lot of different components kind of going into susceptibility for substance use disorders. Let's see, next slide. Okay. So how can I recognize a substance use disorder in someone I care about? So, that, again, this is not an exhaustive list, but some things you may notice would be, I think a lot of these things would set off your spidey senses. I think, if you've got someone close to you that's exhibiting some of these things, you're maybe already noticing them, but sometimes it helps to kind of just put this into written form. So noticing problems with the relationships, right? Not meeting those obligations, things we talked about earlier. Avoiding usual friends and activities, especially ones that were previously really enjoyed. Changes in mood, increased irritability, fluctuations in mood, changes in sleeping, eating, or hygiene habits, and changes in physical appearance. So that can be, related to the kind of hygiene thing, more disheveled, but also could be losing weight. That's something that can happen when folks are using substances instead of eating food, or substances that cause them to lose their appetite, like stimulants. People can have rashes or skin picking, where you're noticing kind of lesions on the face or other parts of the body. So some of those things can be signs of substance use disorders. Obviously, a lot of this too could be related to other problems, mental health problems, not necessarily substance use disorder. So not necessarily jumping to that. Obviously want to talk to somebody, but these are things, to look out for, and maybe ask some additional questions and see what's going on. So how do I have a conversation about substance use disorders with someone I care about? Not easy. Definitely not easy. Even as a professional in this field, sometimes these conversations are really hard. And I think even harder when you've got a lot of emotional investment in the person you're talking to. So not always easy, and it's okay to kind of say, maybe I'm not the right person to have this conversation, if they're willing to talk to somebody else about it. So before going into a conversation, myself included, I try to put myself in the individual's shoes and leave judgment at the door, right? I think it's really important to build up that sense of empathy before going into a conversation about substance use disorders, because, I think based on our society, a lot of us have kind of implicit biases about substance use disorders, how we were raised in our society. And some of those things are hard to let go of. So I think really preparing yourself to let go of those as much as possible can be helpful. And so I think one way that's helpful is to put yourself in their shoes. If I were in their situation, what would I want? I wouldn't want to be bullied or shamed. I'd want to know that someone cares about me. I'd want to be able to make some decisions for myself, maybe. And also, I think thinking about how hard it is to make a behavioral change. If you've never gone through this before, at least thinking about, well, times that I've had to make a change that was really hard. So, for me, maybe it's, I made a commitment to exercising more for my health, and yet I'm sitting on the couch at the end of a long day because I just don't feel like going running, right? Or my coffee in the morning, right? If someone told me I couldn't have coffee anymore, what would I do? That would be really hard. And just thinking about those things that we all struggle with, right? That we all have our vices in some way or another. And so developing that sense of empathy, I think, is really important, because behavioral change is not easy. And so making sure that they're in the driver's seat, right? So if possible, find a comfortable space and a time to talk to the person. So not ganging up on them in the doorway of their bedroom, giving them space to be able to walk away if they need a break or breather, space that they feel safe in, right? And asking open-ended questions without leading. So one way to avoid judgment or coming off as judgmental, even if you're not trying to judge, is to use questions that don't end in a yes or no, open-ended, a lot of how questions or tell me more kinds of questions. So, one option would be, how have things been for you lately? Instead of, you seem off, what's going on? That kind of sets it up as almost confrontational, as you're noticing something is wrong with that person, and it sets it up so that they may feel more judged or shamed. Whereas if you're just kind of asking, how have things been for you lately, maybe that's a little bit more neutral, allowing them to just respond as openly as possible. You want to show that you're listening too. So some ways you can do this would be repeating back things that they've said. So you can paraphrase, but you just want to show that you've heard them, right? So if they're saying, I've really been struggling to quit drinking, you might say, this has been a really hard a few months for you. And so just kind of repeating back some of the things that they've said, showing your support, expressing your support in a phrase that's just kind of like, that must be really hard, showing that empathy for them. And then it's okay to express concern, saying, I'm worried about you, but don't want to make it all about you, right? So don't turn the table, right? So that you're kind of saying how hard it's been for you to watch them go through this. You kind of, again, want to suggest your concern, but also, don't want to take over the conversation. And sometimes that's hard to do with a loved one. And then I'd say let them know you're here to help in whatever way you can, but ultimately any decision that they make about getting help will be up to them. Again, giving them that space. And I think that allows for people that are not ready to make a change just yet, to know that when they are ready, you'll be there for them, and you're not pushing necessarily at this moment, okay? And again, that can be hard to do too. So where can my loved one get assistance? And so I think if you have a conversation, if they're showing some signs of readiness to make a change, they may benefit from speaking to a counselor, maybe a peer support, attending a recovery meeting. So some of those are listed here, which is also not an exhaustive list, but I think many folks are familiar with sort of the 12-step meetings. Some are kind of more religious based, some are not. So, but I think there's something out there for everyone. If you're unsure of the severity of their illness or the recovery needs, there are professionals who can help. I think one of the most approachable ways to get some professional help is starting by talking to a primary care doctor. They can kind of gauge a situation, do some screening, give some advice about next steps, can refer to specialty clinics if needed, that are more focused on addictions. But some primary care doctors too might be very comfortable kind of starting the process themselves, can prescribe some medication to help in certain situations where it's indicated. Some offices have, some ability to consult within their system. So maybe some options there. I will just put in a plug for our Vanderbilt Psychiatric Assessment Service. We call it PASS, here at the Vanderbilt Psychiatric Hospital on the first floor. It is a crisis resource, but it's also really just there for folks that need immediate kind of assistance. So if not sure where to go, that can be a resource for guiding folks. It doesn't, just because you go in there, doesn't mean that person's getting admitted to the hospital, and they may be able to suggest other resources or refer to residential treatment, for example, straight from there, or provide kind of withdrawal management, monitoring in just kind of a short period of time. And then also the SAMHSA website, if you're not familiar with it, I've listed it here. That's the Substance Abuse and Mental Health Services Association, I believe. And that website has a lookup tool to look up mental health providers and individuals who provide specialty services in substance use disorders. It also has other information kind of relevant to this talk, providing assistance to people you care about, and things like Narcan training, how to provide emergency Narcan, and how to get it, that sort of thing. So I do really recommend taking a look at that website. So in terms of professional services, we have different levels of care. And I mentioned I work in a couple of these levels. So the kind of most, the lowest level, sort of most basic, is the outpatient level of care. So this could include seeing a professional in a clinic, maybe once a week, once a month, depends on kind of what stage of treatment they're in. It can be a vehicle for just kind of getting a consultation sometimes, or longer term therapy and medication management. Our program has groups, certified peer recovery specialists who've gone through training as peers in that are in recovery from their own sort of substance use disorder or addiction, but have sort of overcome a lot of the kind of the hard part of it, and they are certified to kind of provide that peer perspective on what it's like going through this, and what are some of the resources too, so they can also direct towards relevant resources, provide some counseling. These can be in-person or virtual options, depending on where you go. And I'll include within this opioid treatment programs too. So people may be familiar with sort of methadone clinics that may require daily visits for methadone at first. And things like BHG around here, Comprehensive Care Center. So those are some different options. Sort of a step up from that would be intensive outpatient. So we talked a little bit about our Vanderbilt intensive outpatient program, which is sort of dual diagnosis, focusing both on substance use disorders and maybe another mental health problem. But I think not entirely required to have, sort of both, but it is a service that they provide. And so usually it's strongly group therapy focused with some individual attention and programming. And there are different IOPs. So ours is in person and 4 to 7 p.m. in the evenings, kind of during Monday through Thursday. So kind of designed to work with people that have a sort of traditional work schedule, so that they can get back to work or whatever they need to do during the day, childcare, whatever that might be. And other programs do offer some virtual options or may have different hours in the morning. So, there are lots of different programs. Partial hospitalization or PHP is usually a couple of weeks, full day programming. So shorter duration, whereas IOP is usually several weeks long. Partial hospitalization is kind of more time per day, but condensed usually into just a couple of weeks. And Vanderbilt actually has a couple of different PHPs for mental health. One focused on more women's health, and another kind of more broad program. And then residential treatment is another level of care. So sometimes people think of this as rehab or just kind of an overnight stay where they're staying somewhere for several weeks. Again, often group focused, sometimes including medically supervised withdrawal management as well, within the scope of what they can handle in that kind of setting, depending on the severity of that expected withdrawal. So residential treatment can be an option for certain folks. There are some limitations with insurance and things with some of these different levels. So good to give a call beforehand and see if you can get in there if needed. And then inpatient medically managed care is in-hospital care. So that's the setting that I mostly work in here at the Vanderbilt Psychiatric Hospital. So here it's a locked unit for the safety of kind of everyone who's there. So and that's not the setting for everybody, but sometimes that's what folks need, and we're able to provide that kind of medical management, typically for folks with kind of severe illness, increased risk for complications with withdrawal, especially for folks that have had maybe seizures from withdrawing from alcohol before. So, or other kind of complex medical issues that might make withdrawing more dangerous and requiring more supervision. Sometimes people come to us because they haven't been able to achieve success at lower levels of care. Or maybe they have simultaneous problems with kind of severe mental illness. So different reasons to kind of get into that higher level of care. And it is sometimes necessary, and we do our best to help folks. But sometimes our loved ones don't want our help. Sometimes it's a mechanism of the illness itself that, again, that primitive part of the brain, that reward system has just so taken over. It's the other parts of the brain can't compensate and can't necessarily think logically, hey, this is not part of my survival mechanism. This is harming me in a way. I think a lot of folks, though, do at some level recognize the harm that's happening as a result of chronic substance use. And sometimes it just takes a little while for that to be recognized. And sometimes it takes lots of different conversations with folks. And so sometimes we'll even see people, in the clinic that are, really kind of early on in that stage and just kind of figuring out what they want to do. And they're maybe not fully ready to make a change, or they want to just kind of cut back a little bit. But cutting back a little bit is sometimes enough to kind of get things going and to let the brain recover a little bit and help develop that insight and those parts of the brain, bringing those other parts of the brain back on board again. And so I think continuing to work with those individuals can be rewarding in its own way, even if they're not fully on board with stopping or getting the full range of help that they may need. Other things that one can do in this kind of situation, community reinforcement and family training, or CRAFT, is a therapeutic technique that individuals in the family can sort of learn how to approach individuals that aren't ready or don't have that insight, how to talk to them. So kind of expanding on some of the things I talked about and with having those conversations, how to support them, how to provide other rewards for them too. So sometimes what someone needs to get out of a substance use disorder is to have something that's more rewarding and hopefully healthier and more rewarding. And so sometimes that can work. We call it contingency management, by providing other rewards for an individual that are healthier while they kind of, stop using the substances. And so the CRAFT approach can really help, especially families with like adolescents that are going through a substance problem. Al-Anon meetings are kind of a 12-step based approach for individuals that are concerned about family members using substances or loved ones, friends using. And it can be a way to connect with others that are sort of in the same position, learn from others, and just kind of get some support. So even if it doesn't sort of move the needle for your loved one, it allows you to kind of to help yourself too. You can't, light yourself on fire to warm someone else, right? You've got to take care of yourself before you can take care of someone else. And sometimes doing that is protecting your mental health and getting that support from the community. I think recognizing what's in your control is an important skill, and so sometimes it can be easy to feel helpless in this kind of situation. So kind of identifying maybe with sometimes with again other supports around you, with someone you can trust. What are the things that I can control, and working on those things when the other things are not going your way. So focusing on that sphere of influence. And then finally, I do recommend keeping emergency Narcan on hand. Even if your loved one is not using opioids, we know, again, these days that opioids like fentanyl are getting into so many things that one thing you can really do to help your loved one in this worst case scenario is to keep emergency Narcan on hand. You can get this as a prescription from a healthcare provider. You don't have to have a substance use disorder yourself to be able to get this. They can prescribe it to pretty much anyone that has anyone they might come into contact with that might need it. And it comes as usually a nasal spray, but sometimes an injectable as well. And I, again, do recommend looking at the SAMHSA website, the trainings for how to administer Narcan, so you know how to do it properly if needed. If you ever had to use Narcan on someone, I also recommend calling 911, making sure that they get to professional help, because it's still an emergency, and we know that the duration of things like fentanyl can last in their system longer than Narcan can. So they may need multiple doses. They may need to be monitored for several hours before they're in the clear. So just like to point that out. And with that, I will stop and kind of open things up for questions. I really appreciate everyone's attention and attendance.
Thank you, Dr. Reddy. It was very informative. Well, this is our time for questions and answers. If you don't feel comfortable asking them out loud, please feel free to put them in the chat. I know that someone had something answered during the presentation by Rianne. So this is your chance.
I'd also be happy to hear about other people's experiences with this kind of thing, challenges, success stories, whatever that might be.
I was just wondering how someone would get that training, the craft training, the family training.
Yeah, that's a good question. Do you mean like as a provider or as an individual, like just kind of wanting to get the benefit from that sort of therapy?
Yeah, as someone who's caring for someone who has a substance use disorder. Yeah.
Yeah, so there are trainings online. I think there are courses that you could take if you wanted to actually be trained in craft. Otherwise, if you just want to work with someone who knows craft, you can look on the website for a provider that knows how to do it and usually working with the family. And so you can learn it yourself. There's a way to do that online, but also looking for a provider that is experienced in that and can work with the family on that. So it's a kind of therapeutic technique. Mm-hmm. Good question.
I have a question. I have a daughter who's in Tennessee. She has actually been to Vanderbilt 2 years ago for a short period of time. We wanted her to get a court-ordered to stay in a rehab retreat or treatment program. She did. They didn't do that, but she did go to one, and she left 2 days. She went to another one. She left 3 days later. She has mental illnesses, plus she has alcohol and drug abuse. And she's very hard for counselors to deal with. And this is hard because I don't live there. I live in another state. Lately, she's been reaching out to me again that she wants to try to get a job again and work. I mean, she was so different. So many years ago, she was so different before she started all this. But I can't get her to go. But how? Like, I'm going to try to give her the information about the 4 to 7 because maybe she's willing to do. She has a lot of trust issues. She has PTSD too. So it's hard to get her in there because she's had bad experiences, which I'm sure other people have too. So how do you help someone who, in a way, I know deep down inside she wants help, but she hasn't had good experiences in rehabs and treatment centers. and she does have a lot of paranoia, So how do I help her get the help she needs?
Yeah. It's a really tough situation. I can commiserate with that. I've seen a lot of patients come through our doors here that, yeah, do exactly what you described. Only come for a couple days and leave, and maybe end up coming back. And we don't have a real way to, in most cases, to kind of hold someone against their will. And we also don't think it necessarily works well that way. I mean, I think to some extent it would, in the early stage, once they're kind of clearing the drugs from their system, I think it can help create a clearer mind. But also someone does have to want to get the help. Now, what you're describing too is also, the interaction with the environment, which she hasn't had good experiences with certain environments. And so, yeah, I think looking into different environments that might make her feel more comfortable. So like an intensive outpatient program is nice because, it can fit in the schedule of a lot of folks. And it's not a locked environment. So certainly
Right.
folks with bad experiences or trauma may feel more comfortable in a space where they know they can leave, right? And they're going to sleep in their own bed that night. So sometimes starting there can be a good way to kind of rebuild trust in the system.
Well, she's also been homeless there in Tennessee for 2 years. Now, she just texted me today. She said that she's been asleep for 2 to 3 days because she's trying to get all the toxins, all the drugs or alcohol out of her system. And that's what she tries to do. She tries to do it on her own. And so then she'll get out, she'll get out of sleeping, and then she'll try to do something, and then she'll take something again. And then she just keeps doing that. Is that a sign that she's trying to get help in her own way? I mean, it's when someone tries to do that, I mean, she's getting closer.
Yeah. It's obviously a little hard for me to say when I'm just kind of hearing about her now, but and not kind of hearing or not meeting her and seeing the whole picture, but certainly it sounds like she's making some efforts. Yeah. I don't think people
I'm gonna actually have her call her Rianne, but see, my concern is she gets angry very quickly. She gets angry at the world very quickly. So she could be talking to someone, a counselor who's very, very nice, and then all of a sudden she just gets set off because there's so much there. I mean, there's a lot of mental issues there. I mean, she has schizophrenia. We do know that for sure. But it's hard when somebody has the mental illness and the substance, and I just think deep down she wants help, and I'm trying to guide her to go to a safe place. I know she's had bad experiences, and I'm sure other people have too, but then you got that on top of it yet with everything else. So I guess if she calls Rianne, or she does, hopefully she won't tell Rianne off, because that's just the way she's used to living now. She tells everybody off all the time. And I'm sure you hear from people. I'm being honest because, it's been a long time now that she's been homeless and using, and it's, we as a family, we can't let her come back until she does something. But she's just being stubborn in her. I know you don't know her history or anything, but she's very stubborn, and she wants things her way or no way. And she's 40. Well, how old will she be? She'll be 45 years old.
Well, hopefully this is what she's doing right now is a sign that she's wanting help, and definitely the information you got tonight with Rianne, hopefully she'll be open to. So.
Okay, thank you, Don. Don knows about the situation.
I'm going to ask a question from the chat, and forgive me with my pronunciation. Can a naltrexone be used for addiction other than alcohol? And can you elaborate on medication treatment for different addictions?
Yeah, it's a big topic, but I can give a quick primer on it. So the quick answer to your question, can naltrexone be used for other addictions other than alcohol? Yes. I would say naltrexone is sort of our broadest medication for different substance use disorders and other types of addiction too. So, sometimes we'll use it for sex addiction, use it for inhalant disorders like huffing. I've used it for stimulant use disorders. So lots of and it also has a role in opioid use disorder. So it's a little bit trickier in opioid use disorder, getting people started on it. It has some interactions with the opioids if the opioids aren't cleared from the system fully. But yeah, naltrexone, or the injectable form of it, the monthly injection, can be used for a lot of different substances. So it's a really nice option, usually pretty well tolerated. For other substances or for other medications, so like for alcohol, naltrexone sort of our go-to, but we've got a couple of other options. Acamprosate. Sometimes we'll use disulfiram, the one that sort of makes people sick when they drink, but not always our preferred option. And then for opioid use disorder, we use Suboxone, buprenorphine, methadone, and naltrexone, or the monthly injection form of it. And so lots of different options for those two. Now, for other substance use disorders, we don't have as much evidence for them, other than for tobacco use disorder. So folks wanting to quit smoking or vaping or dipping do have quite a few options as well. But yeah, for some of the other substance use disorders, we're using some of these things off label, like the naltrexone, a few different options, which are, I would say, somewhat effective. But we also know that for things like stimulant use disorder, kind of being involved in community treatment, psychosocial treatments, things like the contingency management I mentioned, those are really ways to kind of move the needle on those substance use disorders. So that's a great question.
I have
Yeah.
a question.
Oh,
Oh,
you can.
oh, go ahead.
Go ahead, and then we'll go to Len. Go ahead.
Oh,
Are you?
oh, are we?
Yeah.
You're good.
So we have our son's in rehab now. You're eternal with us. And I get the counselors or the person that's working with him will give me a kind of update. She called me today, told me kind of where he's at. And he says that he can't commit to sobriety. And I know some of it, he's like, I just want to be honest, but he's not willing to say, I'm going to commit to this. So do you have any advice, maybe how to encourage him and kind of when he comes back, come back to live with us, just ways that maybe, because you said like not the yes and no questions, but just some things that might be helpful for kind of coaching him to want to get well, to commit to it, I guess.
Yeah.
In a sense.
Yeah, that's a great question. Yes, I think some of those open-ended questions would be helpful, but kind of asking him, I think, if sobriety is not his goal, what are his goals? Where would he like to be in 5 years? Where does he see himself being in 5 years? And where do substances fit in with that? Sort of trying to understand how do his future goals align with what he's doing right now, and get him to think about that a little bit. And then saying, what can we do to help you meet those goals? And whether that includes full sobriety or not, I'd have to meet with him and talk with him to, I think, really know if that's needed. But for some people, it's not. Like slowly cutting back over time, for some individuals does work. And so getting connected, I think, with someone who can kind of continue to have that conversation with him over time, to develop, that focus on his future motivations, I think can be really helpful. So maybe right now is not the time for him where he feels ready to fully commit to sobriety, but maybe down the line he will be. And again, continuing to have that conversation, where hopefully he's cutting back over time and developing that motivation. So sometimes that's talking to a professional, sometimes it's talking to like a kind of a peer counselor. I think there are a few different ways you could go with that.
Len, you had a question.
Oh, no, I didn't.
I
Len,
had,
not
I
Len.
had,
Is there another Lynn?
It's
oh,
Len.
I'm sorry.
Len. Len.
If she has a question, let her go ahead.
No, she didn't. She just
All right, I was looking
Len
for
and
my,
Lynn sounded the same.
all right, I was looking for my unmute button. Uh, Let me give you a teeny bit of history. First of all, I'm 75. I got sober at age 45 after my second AA meeting. I'm a traditionalist when it comes to AA, but I'm a liberal. So I guess I'm a conservative and a liberal. I always like to be in the middle, but anyway. And I think that, you know, my way of getting sober is just anecdotal, and only applied to me. But what I want to say is that I think that it sometimes can be really helpful if the people that want to help their loved one, and we'll just lump everybody into that category if it's okay, that would include uh, uh, friends, family, etc., or even just a person you meet on the street or in a parking garage for that matter. Uh, but somebody talking to another person who has the problem, and I don't know about drugs. Oh, I smoked a little marijuana when I was going to school, and I took drugs once, and that was it. I just drank a lot of whiskey, unfortunately. But I got sober, as I said, at age 45. And the first thing that happened was one of my very best friends, who I went drinking with, told me that people in a small community where I lived were beginning to talk. And I just got angry. And I had to go on until finally I called up a fellow that I knew had gotten sober. And I said, you know, I need to go to an AA meeting. And so I reached my bottom. You know, some people's bottom is higher and some is lower. And AA talks about that. But my whole point here is that when I went into the second AA meeting, I asked the fellow sitting next to me just before the meeting was over, whispered over, how do I get sober? And he said, well, you know, just go home, don't drink between now and the meeting tomorrow night, and come back. And I did that, and I did it for 30 years. Now, you can say, oh, congratulations and all of that, but that was something that evolved over time because I was constantly talking to other people that had the same problem. And they weren't really telling me what to do directly.
Right.
You know, parents want to do that because they love their kids. You know, but what it was, you know, the other people I talked to at the meetings, and I'm not saying that's the only way to get sober, and they don't have to be Christian church meetings. They can be in a bar, you know, that closes down at a certain time for an hour to have a meeting. But having somebody who has been through it. Also, as far as going into these institutions, I hate to admit it, but I've been in 5 psychiatric units over the years and continued somehow to try lawsuits and criminal cases in court until the very end. But you know, it's a situation where, you know, if you understand initially that all you got to do, and that's really hard at the beginning, is not drink today and you don't worry about tomorrow. When you get to tomorrow, you don't drink, you know, for tomorrow, or that's then becomes
Take it one
today.
day at a time. Yep.
Exactly.
And it's one,
Len, what I'm hearing from you is, again, with your story, that there's support. I'm throwing this out to Lynn. I'm not sure your partner's name, Lynn, that brought this up, but I was just gonna quickly interject before we take another question of sobriety is scary for some of us. I'm not completely sober, but I'm able to manage a beer occasionally here, but I can't go to the whiskey anymore. And I know that. But sobriety is scary in our culture because the idea you're going to lose your friends, whether they're real friends or not, the friends at the bar, your drinking buddies, etc., whoever you shoot up with, etc., they're not going to want to hang out with you anymore. And that can be very daunting. And as caregivers, I'm a caregiver to a 19-and-a-half-year-old who I've talked to about substance use issues, so they don't repeat the same mistakes as mine. But what I'm hearing from Len and from others is helping your loved ones find the support where they best thrive from it. It may not be rehab. It may not be AA. It may be going to a group, a support group, whatever, being able to say, this is hard. This is why it's hard. So sobriety is not easy in our society, because who wants to hang out with the guy, the woman or the man who doesn't want to have that drink after work? Who wants to go to the camp out where they're gonna not smoke the joint that gets passed, etc. So know that it's a hard decision. Your loved one has to be in the right spot. Some of us hit bottom at different levels, but it's hard. But being supportive of them and being there when they're ready for the help. You can't force the help on them.
May I say one other thing? And I know maybe
very quickly, Len.
I'm depending on being old. What I'm really, my real point is that, I can tell my story to somebody, not jump on them, but tell my story. And they will realize, if they're a real alcoholic, whatever that is, that I know what I'm talking about. And they may get interested, and it may be 6 months and I get a call from them when they're really hurting and they want to, again, hear, how do I get sober? That's all.
Yeah, I think patience and playing the long game is important. Yep.
Since we're getting close to time, are there any more questions for Dr. Reddy? All right, I'll take that as a no. I do want to, before I close the session tonight, let you know that Eileen Wolf is here tonight. She is our caregiver coordinator. And most of you, I think, tonight are coming to this as caregivers to loved ones. I want to encourage you to reach out to her at caregiver@namidavidson.org. We have groups, education classes, etc. She has her own family history with mental health issues. And again, finding peers that understand is the most important part. And that's why NAMI exists. We're a peer-led organization. So with that, I want to thank Dr. Reddy for taking your time tonight for a very informative session. Several people in the chat thank you also, Dr. Reddy. I want to thank Tracy Glasgow for coordinating tonight's session with me. And I want to remind everybody, as registrants, you will receive tonight's PowerPoint in an email from me once Dr. Reddy forwards it to me. So you can follow along with the audio version that will be posted on our YouTube channel as early as tomorrow. You can look that up at NAMI D Info. That's our channel on YouTube. It'll also be linked in my Monday newsletter, which all registrants are on. So we appreciate everyone supporting our educational sessions and other programming. So please feel free to reach out to me directly at outreach@namidavidson.org if you have any questions or suggestions for future sessions. This was a topic that several of our members wanted to hear. So I let Tracy know, and she was lucky enough to find Dr. Reddy, and Dr. Reddy was gracious enough to give us her time tonight. So I want to wrap it up by once again thanking Dr. Reddy.